of Jenna Blair. Go ahead, please.
Hi, thanks for having me on today. First off, I'd like to remind the working group that Borrelia are relapsing fever germs, and just like the rest, they're capable of antigenic variation. That fact alone makes it a ridiculous notion to attempt to vaccinate against it, and asinine at best to say that vaccines for spirochetes work by turning human blood into tick disinfectant. Secondly, OSPE is panthyresis, a fungal-like endotoxin that causes immune suppression, and that means that it is the opposite of a vaccine. For the last 18 and a half years, the activist groups Action Lyme and now Truth Cures have been filing complaints with every .gov agency anyone can think of. This was even brought to the FDA formally. The OSPE causes immune suppression and a systemic disease, say Dattweiler and Philippe. And I'm directly quoting here from a patent owned by David Persing and Robert Schoen, who say that OSPE causes a disease indistinguishable from late chronic neurologic Lyme, but never once has any .gov agency or MD answered the question as to how OSPE alone could cause the same exact multi-system protein disease. No spirochetes, same disease. The science was settled as far back as 1986 when, for example, Paul Duray, who's a top Army pathologist, reported that the lymphocytes in spinal fluid looked like leukemia or lymphoma and appeared to be Epstein-Barr transformed. Also in the 1980s, it was Alan Steer himself who reported that this was like pseudolymphoma. Gary Wormser has reported that OSPE causes immune suppression 3 times now. So, do we really not know anything about relapsing fever organisms? Post-treatment Lyme disease syndrome, or chronic Lyme, or whatever you want to call it, is really an acquired immune deficiency, or what the NIH calls post-sepsis syndrome. Everyone says so. There is no question. Every subcommittee needs to be viewing the disease through the lens of this really being a B-cell AIDS. The only way forward is for HHS to admit the role of OSPE as a self-disabler. OSPE could never have been a vaccine. It never was, and it never will be because it is a fungal-like endotoxin. Spirochetal diseases are not easily treatable infections. They are acquired immune deficiency detonators with a cancer-like twist. We demand that you answer as to what the structure and function of OSPE is, and that alone will give you the foundation to squash all of the controversy. If this committee fulfills its intended purpose altruistically, you will look at the existing science to validate what is really going on with Lyme disease, and you will recommend a criminal prosecution and stop the madness. TruthCures.org has all the data in their charge sheet. Thank you.
And everybody wants this to go really, really well. So we feel a lot of pressure because this is part of the $6 billion act. So even though there was no money that was attached to the work group itself in the act, people want everything that's part of the Cures Act to be successful.
But with HIV, one of the challenges is that the way things were set up in the beginning have messed us up for a long time.
Right.
So with the testing system, most of our public testing is done outside of the healthcare setting. So, and it was done. I remember when it gave people positive test results in '85, we would just kind of say, okay, take care of yourself, eat good food, get lots of rest, good luck to you.
Yeah.
And it was kind of, there was
That's
nothing.
where we are.
That's where we are, because we're
Okay.
saying, here's what your disease really
Exactly
is, and they're
what
like,
we are
okay, what's
told.
the treatment? Well,
Right.
the treatment happens to be something that'll probably come from oncology, because we're talking
Yeah.
about bad B cells here. And that death rate, we don't even have a clue what the death rate is because the disease is not being diagnosed.
And you've got the same issue you have with HIV, that is really kind of the cause of death is something
Yeah,
else.
it's never,
Right.
And
never
it's
Right.
not the
Exactly.
driving factor
Yeah.
behind it.
Put us here in 1970, when it was discovered, okay, and it's getting worse and worse and worse, and they're admitting that, oh yeah, this is a really bad thing. Jump all the way to 1994 when they changed the case definition, and we went backwards.
We have gone backwards.
Right. And we are still nowhere
Yeah.
40 years later. 40 years. You're looking at 15 here. We're at 40.
What other medical condition goes backwards in 40 years as far as treatment and recognition?
I think that
And testing.
is, I can't think of another one.
No.
How do you select the chair and co-chair?
So they were selected.
Are they already?
So they've been. So we don't select anybody in this office. We make recommendations. So they were selected.
Are they already?
Will the subcommittees also be open to the public?
So subcommittee meetings typically do not end up being open to the public in all cases.
Will they be advertised so that we know there is a subcommittee of a certain type and what their scope will be?
You'll know the structure for sure,
Okay.
and it will not be invisible in terms of what work is going on.
Okay.
Part of it ends up just being that if you have like 6 different entities operating all at once, it gets a little hard, and quite frankly, most of this work is going to be done by conference call. So they're not going to be coming together physically for the subcommittee work in a lot of cases. The subcommittees, remember, do not make decisions that go beyond kind of the work of the subcommittee. They draft materials, basically, is one way to think about it, that then come to the working group. So the subcommittee may have discussions among themselves, they may vote on some issues, but that's just relevant to the work of the subcommittee, and that has to then all go forward to the working group.
Would you be able to request to be part of a testimony or something that a subcommittee is working on?
So you are able to request whatever you want. You can request.
The act is very clear. We have 3 stakeholder groups that we are charged to listen to and represent, and that's what we do. And this is also not something where, because we're HHS, we're going to have we're going to be on HHS side for our agencies. I mean, this is really just our job is to have a fair and open process and to move us forward. So it's not to achieve the goals of any one agency of HHS or any one program. And it's also on the other side, not to achieve the goals of any one partner or any one external stakeholder group as well.
Well, let me just clarify. I mean, one of the things the subcommittees will be doing is asking the NIH for a report on what they're doing and other agencies. So each subcommittee, this is a later topic, but they'll be getting data from these relevant groups.
John, so I put the immunotherapy with treatment, and I put vaccine with prevention. Is that
I'm feeling for you,
saying?
Ben. That's a lot. That's a lot for, I know it is.
Or do you want to, or we put them as separate and pull them out? I wasn't quite sure. It sort of sounded like it was towards combining was,
Yeah,
but I don't know.
yeah.
I don't know if, I think that in listening to everything and thinking about it, I respectfully disagree with what you said, only from the perspective of that we have to think about what kinds of people are we going to put on a subcommittee that's going to look at that issue. So obviously the immunotherapy and the vaccine would seem to be, similar, and I don't know about the new drug development, but those would seem to be maybe the same type of people that might be on that kind of committee, where if we stick it in prevention, it's unlikely that there's so many other types of prevention that don't involve the human organism, shall we say. So I think we should put it in a separate, for our purposes. It doesn't mean NIH, that I don't think it means much difference to you, but I think from our perspective it does.
Right.
So
can you review for us, Rich?
I think so if we're going to pull things out, then basically we'll move this group up, and we're getting past the point of capacity, unfortunately, to...
Pat?
Yes, I think this is the opportunity to bring up the issue I mentioned yesterday, and we agreed we would hear today, and that is we're talking about other entities from which to gather information, and the other entity which I believe needs to provide information is the other government all-federal working group on tick-borne diseases. And I think we need to find out, first of all, what their charter is, who charters them, and what kinds of information, what do they have, and get perhaps what they have been discussing. Because otherwise we have two separate groups that are dealing with tick-borne disease information at the federal level, if you will, at least looking at and collecting and so on and so forth, and we won't have any idea what has been done or what is being done.
Can I comment on that? Because I think you're talking, there are two of those that I'm aware of. There is sort of an all-federal, and both of these are informal working groups, but there's one that's an all-federal tick-borne disease integrated pest management working group that's been kind of in operation, probably for 5 or 6 years. Candy Broussard and I, when she was at the EPA, we actually sort of got that group started. Of course, USDA has those parts. So that's, for the record, that's published, it's posted online, but that's a good sort of starting point to kind of get an understanding of what the different, and there were 10 federal agencies that were involved in that effort. Dan Strickman and myself edited it when Dan was at USDA. So that's available as a good starting point. The other group I think you're referring to is the informal HHS tick-borne disease working group, and that was a group that actually CDC and NIH informally started just so that we could begin to coordinate our activities. There's been a lot of talk about duplication and overlap of government, and so this was a group restarted so we would be aware of what each other's doing so we could coordinate our work together. A great example of something that came out of that was that with the reservoir-targeted vaccine, NIH funded development of that, but they wouldn't fund field trials for that. So we actually funded CDC field trials that gave rise to one of the reservoir-targeted vaccines that's being studied right now. So another thing that came out of that was referred to earlier today as the serum panel that's used for development of new diagnostic tests, and it's a 450 some odd panel, and it's used so that companies who have a diagnostic test ready to go, or even researchers, can evaluate their tests with very well characterized sera. evaluate their tests with very well characterized sera. And so that was a combined effort of CDC, NIH, and FDA, because CDC and NIH co-funded it, and then FDA works together with new test distributor or producers to be able to get those tests adequately validated.
For clinical studies, there'll be testing samples from your intended use population, patients suspected of Lyme disease. And it will also include testing with well-characterized samples from confirmed Lyme disease cases at different stages of disease so that we can report on the different stage-specific performances that both Marty and Claudia discussed earlier.
And subcommittees are really going to be the groups that are going to be kind of, it's really where like a lot of the reviewing of the data, discussion of the data, the preliminary drafting, and it's kind of like that's where the work's going to happen. Because when you look at the act and the number of different areas that we're going to have to cover in the report, it's a lot of ground. And so you can't do that just in one group. And so each group will be organized around some specific sub-issue. And then they'll have there'll be a process within that group to review that evidence and to talk about it and to identify gaps and to make recommendations. So there'll be opportunities for additional people to come in and be on the subcommittees. And then there also will be the opportunities for people to come in and present to the group and to do the public comments. So at this point, we will, it's all top secret still, and we'll kind of see where it lands. I don't know where it's going to end either, because there are 2 more steps before we're done, and it can change.
Sure.
So I think I can understand why you have that concern, because typically what people look at is how many other committees have you been on and how much have you done that's like this. And so processes like this tend to get people who have been more engaged and have a longer resume in the area.
Right.
So those were, and then of course we did the webinar series that has been referred to. So all those things just to say that working group is informal. I'm not sure if it was a charter or not. It was just several of us that got together. We should know what we're all doing. Is we should talk about it, share notes, and work together rather than work in parallel, separate universes. It's not a formally recognized HHS group, but that's all open, and I can provide that information. I'm part of this group and glad to provide that for either of those.
Pat, I have HHS working group on Lyme and other tick-borne diseases, webinar on Lyme disease and Borrelia persistens.
Yeah, I
Mary, yeah, and it's CDC, FDA, NIH under HHS. And it's a very thorough discussion of a little bit of pathogenesis that they can't figure out exactly how it's happening, a little bit on using ticks for culture and how they are finding Borrelia in ticks. So there is this particular group, and it's apparently informal.
I was privy to that and on that webinar, and I understand all that, but I think that because they are existent and they do carry clout when patients or even myself as an advocate and physicians saw that, they took that to heart. There is a working group, and whether you're totally official or you're not official, it's a group. And I would certainly, I appreciate you know, your little summary there, but I think I would like either to get some kind of report out of that, and if it is indeed going to continue now that this working group is, you know, in existence, I think we need to know that, and, you know, so that can become part of what we base our things on.
Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode for the duration of today's conference. Today's conference is being recorded. If you have any objections, you may disconnect at this time. And now I'd like to turn today's meeting over to Dr. Ben Beard, CDC. Thank you. You may begin.
Thank you. Good morning or good afternoon, depending on where you're calling in from. My name is Dr. Ben Beard. I'm Chief of the Bacterial Diseases Branch in CDC's Division of Vector-Borne Diseases. On behalf of both CDC and also the Department of Health and Human Services Working Group on Lyme and other tick-borne diseases, I want to welcome you today to our special webinar on vaccines for Lyme disease, past, present, and future. I'd like to begin just by emphasizing that the views expressed in this webinar are those of the participants and do not reflect the official policy or position of CDC, the Department of Health and Human Services, or the U.S. government. As many of you will know, Lyme disease is the most common vector-borne illness in the United States. In 2013, there were over 36,000 cases reported, making it the fifth most common reportable disease in the U.S. These are reported cases. The actual number of cases occurring each year is estimated to be around 10 times this number. Since becoming nationally notifiable, Lyme disease has been increasing steadily in the U.S., both in case numbers and in geographic distribution. Consequently, identifying and validating effective prevention and control tools and methods is one of the highest priorities at CDC. The primary objective of our webinar today is to review the history of human vaccines for Lyme disease and discuss the prospects for next generation human Lyme disease vaccine.
You know, so that can become part of what we base our things on.
So
We wanted to show you that we valued your time, so we tried to organize
I
what
just
we
used
wanted
a whole
to.
bunch of my time.
Yeah, but it is yours. So we
And I will let
wanted
you know,
to be
I did set an
organized.
alarm for an hour and 5 minutes, so that'll go off at about that time.
About 5 o'clock.
It's an hour and 5 minutes, so probably a little bit before that, because we have 38 minutes left.
Okay, we can do it.
Okay.
Could we ask just,
Sure.
I know your background, but maybe how you three got involved with this, just so we know who you are.
And our stories are a dime a dozen, and that's why, in one way, my story doesn't matter. So I'm going to skip it, but I'll tell you if you'll extend the time. Because
what's bargaining already.
Because what's more important is the greater good.
Yeah.
Not love of self. So the difference, why our stories are important, is because we can't be diagnosed. You know, the ELISA will catch a true positive serum sample 15% of the time. So frankly, you know, the post-mortem diagnosis of tissue, I'm sorry, do you need to?
That's
okay, is irrelevant It's too slow. It takes too long. And that's the distinction. There are parallels. You're right between that you've identified. But the glaring absence of a parallel that I wish we could draw is becoming diagnosed with HIV/AIDS is easy, but for us it is not.
And just to kind of, I mean, you are welcome to tell me whatever you want to tell me. But one thing I think might be helpful is, in this role, I really am going to be like a arbitrator. I mean, so, I'm not the content expert. I'm the decider. I'm kind of the facilitator of the process. So there's some things that I think you want to tell me that are kind of more focused on facts and issues, and I'm happy to listen to those, and I will take them in, and they'll be kind of part of my mental framework for all the issues. But they're probably not things I'm going to be acting on. And so I kind of want you, so like the process is the part that I'm in charge of.
Right.
And so I just want you to kind of keep that in mind so you don't miss the process stuff.
Right. I can summarize in less than 60 seconds what our primary ask is, if you don't mind.
It's always helpful when people are clear.
We are concerned that your work group will consist of the same people who have been on these types of work groups for these issues for 4 decades. Obviously and effectively, because we're still here needing to form another work group for a completely ambiguous process. All we want to know is that there will be room at the table. And I think you can lump those people into 2 sides. You've got ITSA, you've got ILADS. We're neither of those. And we think that it's really important that this third perspective be included, or you will continue to, what is the definition of insanity?
Repeating the same things.
Right, and so we're concerned that your players are going to be those same players, and you're going to miss an important piece of the story. So that's our concern.
Our first speaker is, the title is Why We Need a Vaccine for Lyme Disease, given by Dr. Stanley Plotkin. Dr. Plotkin is Emeritus Professor of the University of Pennsylvania. Until 1991, he was a Professor of Pediatrics and Microbiology at the University of Pennsylvania, Professor of Virology at the Westar Institute, and at the same time, Director of Infectious Diseases and Senior Physician at Children's Hospital of Philadelphia. For 7 years, he was Medical and Scientific Director of Sanofi Pasteur, and is now consultant to vaccine manufacturers and nonprofit research organizations. He is a member of the Institute of Medicine of the National Academy of Sciences and the French Academy of Medicine. His bibliography includes over 700 articles, and he's edited several books, including a textbook on vaccines. He developed the rubella vaccine that's now in standard.
So many mistakes were made with the original vaccine. The manufacturer advertised directly to the public without convincing physicians of the importance of vaccination. And it is recommendation by physicians that determines whether the public uses a vaccine or not. They launched a pediatric study too late. And by the way, the pediatric study showed that the vaccine would have been even more effective in children than in adults. And the manufacturer also failed to engage patient groups interested in Lyme disease, patient groups who are concerned about chronic results of infection by the bacterium. CDC, in my opinion, made a mistake by assigning the vaccine recommendations to staff that had no direct experience of Lyme disease. That is, staff that were not stationed in the Northeast, and making weak recommendations. There was weak support by opinion leaders, there was opposition by patient groups, and as I mentioned, the class action lawsuit.
Operator, I think we've got one more commenter. Is that true? The line of Kathy Nodal. Go ahead, please.
Good afternoon. The biggest complaint I have about the crazy controversy regarding Lyme disease is the vehement denial of facts, truth, and the real science that exists today. There is only one truth, not tailor-made versions of it to suit each and every one of us. This committee will have failed everyone if the U.S. government does not state for public record what exactly OSPE is, or outer surface protein is, and what its structure and function are. The answer to this will cut to the chase and answer all other questions. If we know it is a fungal endotoxin that causes immunosuppression, then we can end this false dichotomy over persistence and antibiotics. Killing spirochetes is not the answer to this disease. There has been a crime committed here. The crime is the falsified case definition of Lyme disease. We demand prosecution of the individuals who are responsible for changing the case definition at the 1994 Dearborn Conference chaired by Barbara Johnson of the CDC and aided by Alan Spear's research fraud used to falsify the case definition. This conference facilitated the approval of the science of the since failed Lyme-Rix vaccine, which has been pulled off the market for causing the same multi-system disease as those of us suffering from neuro-Lyme. OSPE was in the vaccine, and OSPE and other lipoproteins like it are shed with blebs or other exosomes by spirochetes. Spirochetes cause disease by going straight to the germinal centers of our lymph nodes, see the work done by Nicole Baumgarth and Steve Bartow. The current testing makes absolutely no sense when you understand that Borrelia are relapsing fever germs. Borrelia is differentiated by their flagellum genes, or DNA. Since all relapsing fever organisms are capable of antigenic variation, they can change their outer surface protein as a way of evading the host immune system. The only scientifically valid way to test for Borrelia infections would be to test for flagellar antibodies instead of outer surface proteins because it is specific and it never changes. Testing for so many antibodies all at the same time is not logical or valid by any standard. Yale's Pickering and Flavell patented a test in 1991, patent number 5618.533, which is 94 to 95% accurate during all stages of the disease. This is obviously the test that should be used. Until we get the correct definition of the disease, we will never find the cure. We have wasted too many years and too many dollars trying to fix a disease that is currently defined incorrectly by design. I am tired of watching my friends die and suffer torturous life due to this crime. The insanity of it all needs to stop now. Go to truthcures.org for the scientific validation needed to prosecute this crime.
Well, so what's the situation now? There is the opportunity for a vaccine, or really multiple vaccines, against Lyme disease. There is another company in Austria called Valneva that is developing still another vaccine based on the protein of the bacteria called OSPA. And we'll hear more about the proteins in the bacterium that could be protective when used as vaccines later on in these presentations. At any rate, that is a second possible vaccine that could be developed based on OSPA.
You know, so that can become part of what we base our things on.
And you know what? I am going to skip right to folder 4.
All right.
Right.
And I'm going to say there is motivation for these people to obfuscate what the disease really is, which is an acquired immune deficiency. Said we have a whistleblower on our side. She blew the whistle in 2001, and here we are 16 years later talking about it. She blew the whistle on this testing.
And she was from where?
She was a scientist at Pfizer, and she did
analytic
validations.
chemist. Right. That's why
She was an
understood.
analytical methods validations chemist. And so what she did was, does this do what it's purported to do or not? Right? So she was the perfect person to look at the testing and say, does this testing work or does it not? And she said, wow, no, it doesn't. She was a support group leader in Old Lyme, Connecticut. And she started getting calls from people who got the Lyme-Rix vaccine who are saying, what's going on? I have Lyme again.
So the motivation for establishing your group is that these two major factions have kind of slightly different perspectives, but they're kind of, one's benefiting from the patients, the other is sort of the benefiting from the industry, kind of the government perspective, the establishment perspective.
Right. They're saying, oh, Lyme disease is no big thing.
Right.
The testing is accurate.
It's a bad thing.
Yeah. And the other side, the ILAD side, they're carpetbaggers. They're taking advantage of the patients.
$3,000
do you
initial appointment,
Right.
cash only. We won't accept insurance
got
because
these
we're
people-
afraid of our license being revoked. And
Yeah. You got these people, millions of people who can't get diagnosed because of
to
the
treat
testing.
you for a non-HIV/AIDS outcome with antibiotics. I mean, no.
These are just a few things that we pulled together under point 4 that demonstrate.
I can make.
It's all yours.
It's not, and that actually not. But to figure, you're our first group who's formally come to us and presented us with papers and stuff. And so Debbie and I are going to have to think about how we do this because, you know, like I said, my job is to be a facilitator.
Right.
And so you're the first group. You're not going to be the last group. And, you know, I want to take in what people have to say, but I don't want to consume it at a level where I'm kind of lose my ability to be a facilitator. So we're going to take these, but I don't know what we're going to do with them.
Sure.
But we will keep them, and we will figure that out.
I would just hope that you read them.
I'll take a look at them.
None of it is our opinion. None of it is us.
Yeah.
It's all peer-reviewed science. It's all, I mean, the most important thing that I think that you probably, with your nursing background, will find fascinating is this is the CDC conference, consensus conference at Dearborn, Michigan, that was called for the purpose of testing the ELISA, standardizing the testing for Lyme disease. So all of the labs, do you have an invitation to this group? Here's the invitation to this consensus conference, where they invited all of the labs to come perform this test on positive serum samples and to give their feedback as to the efficiency of the test. And you'll see that those labs, on average, say this test, which is the ELISA that we currently administer for Lyme disease, will positively catch positive serum sample 15% of the time. And you'll see the results in the feedback basically saying, dear God, this can't be the test. This doesn't work 15% of the time. But that's our test.
And so this is 94, and so no improvements in the
No, that is the standard that we have today. So you have pre-Dearborn and you have post-Dearborn.
And same test, same outcomes.
Well, they changed the case definition of Lyme disease at that juncture.
And there you go.
Here's the simplest summary right there.
I assume we need better tests. That's one of the things we would advocate for.
There is an accurate test already,
And
patented by Yale.
And what's the status?
They're just sitting on the patent. I can tell you the patent number.
Huh.
5618533.
And they don't.
And it does meet the FDA validations requirements for diagnosing Lyme disease. It says all that you need is a positive band 41.
And they have not submitted it for review at the FDA?
No, and they didn't use it to validate their other patent, LymeRx.
It will catch the majority of the positive Lyme cases, whereas the ELISA will only catch the 15% that fall within a category of a hypersensitive HLA arthritic knee type of outcome. The outcomes of the other 85% include your neurological cases, your immune suppression cases, the sickest people.
The Lyme vaccine trials began in 1994. There were two major companies that had their own Lyme vaccine. Each recruited over 10,000 people to participate, half of whom got placebo and half of whom got the Lyme vaccine. So only one company actually went forth and got approval for to market the Lyme vaccine, and that was SmithKline Glaxo with Lymerix. And that came out on the market in 1998 and then was withdrawn in 2002. The reason being, cited by the manufacturer, was that there just wasn't enough interest.
People weren't buying it, people weren't using it, the sales were poor. However, it maintains FDA approval to this day.
For me, it was a very exciting project. The OSPE vaccine was actually created at Yale, so it's a Yale story, and then went on to go from bench to bedside, so to speak.
The Lyme disease vaccine was important for two reasons. First, it taught us to actually look more closely at the biology of spirochetes and how they host adapt to their various microenvironments. Second, it also showed us that we have to be very careful when we develop vaccines in general so that we make sure we alleviate any public concern regarding safety of vaccines before they're mass marketed.
So Yale has a diagnostic test that is not that is.
Do you want to tell them the patent
specific,
number?
and it's not.
Do you know it?
These would be all things that will come out of the meeting process, I'm sure.
But it won't if we are not represented.
Absolutely
But you will, each of you would be able to come and give public testimony. At the bare minimum, that is open to everybody, every single individual. So there is no way whatsoever that this will not get entered into the record. I mean, like, bare minimum.
Yeah.
That is going to be.
Just a question.
Okay,
For Yale, you say they do have a diagnostic test, but they're not submitting it for?
What happened was Yale developed Lymerix, the failed vaccine. They also developed a valid test method to detect Lyme, which said that band 41 is diagnostic by itself. But they did not use that valid test method to assess the outcomes of their vaccine trials. Instead, they used the Dearborn method that came out of the Dearborn Serologic Conference.
Why would you not want a test that would accurately diagnose Lyme disease after you knew your vaccine trial had failed and was causing the same outcome?
Exactly.
Because you don't want to be able to positively identify the victims of your failed trial. And now we sound crazy.
No.
And that is when the door shuts. But these are not our words. You can look at Alan Steer's report from that when he went to Europe and conducted testing to determine on these positive blood serum samples where they would show up on the Western blotting, where they would show up on the ELISA, thereby knowing exactly where the cutoff needed to be so that when he came back home for the Dearborn conference, the proposed ELISA would exclude the sickest people who fall within that 85% range and would only diagnose the 15%, thereby the people who participated in the vaccine trial would take a test. They say, I have Lyme disease, the vaccine gave me Lyme. Okay, well, here's your ELISA. Well, it's negative, it didn't give you Lyme.
Can I jump to our visual aid here?
I see what you're saying now.
Yeah, and it's a pretty quantum leap.
One quick question.
Sure.
When was the Yale trial for the vaccine done?
Oh, the trials happened throughout the 90s.
So did they start before 94? Or
Yes.
94? Okay.
Yes, they started before 94, probably 91, 92.
Some people can be seriously ill from Lyme disease, but the majority are treated very early on and do quite well.
The Lyme vaccine story is an incredibly complicated one, and prevention of Lyme disease continues to puzzle us.
changing, so I've been around long enough that I've seen things that were true,
For
not
so
be true
long,
again,
yes.
and lots of other things. So you've got a
Sure.
figure.
Yeah, and this is to facilitate explaining why simply addressing the terrible testing will not fix the problem. So here's our claymation spirochete.
Okay.
Handmade.
And it's covered in these little blobs. These are outer surface proteins. Outer surface proteins, or OSPs. There's OSP A, OSP B, OSP C, OSP A and B are on the same plasmid, right? These are endotoxins. Are you familiar with that term at all?
No, I'm not.
So endotoxins are really bad. But these OSPs, OSP A in particular, I called an endotoxin. What it does is it causes sepsis. Very shortly after that septic response, the immune system is simply shut down because these OSPs are fungal in nature. So it's like, I'm sure you've heard about the New England Compounding Center scandal, right? It's the same idea. If you look at the long-term outcomes of those victims, and you look at the long-term Lyme patients or the chronic Lyme patients, we avoid that term.
You prefer long-term?
We prefer post-sepsis.
Okay, post-sepsis.
Post-sepsis syndrome, it's a term that the NIH uses. And it is a condition of immune suppression. And it is permanent. And so the real issue is the reactivated viruses. So that's one parallel that we draw with HIV/AIDS.
Right.
Because it's not the virus itself or the spirochete itself that is causing disease. It's these immune suppressive antigens that cause the reactivation of the latent herpes viruses, the CMV, the Epstein-Barr. And those in turn cause this fatigue. And we Lyme patients get dumped in the chronic fatigue syndrome bucket or ME or whatever they're calling it today. The fibromyalgia.
Depressed.
The psych
A lot of
meds.
psychiatry. That's where they send us.
This is the source of all of our struggles here. That these guys who changed the case definition, who had financial interests in a vaccine, which is impossible, and test kit empire,
They held patents.
They all held patents. And so they changed the case definition so these acquired immune deficiency cases could not test positive. So that's the reason addressing the testing alone will not work, because you're still not talking about what the real disease is, this post-sepsis immune deficiency. So, if you go on talking about the disease as a condition of either chronic spirochetes or not chronic spirochetes, and looking at the research that supports one of those two sides, like we have said, you're not looking at the right research. And on the back page of here, we've provided some names of some scientists who say, these fungal endotoxins, or OSP-A, or PAM3-cis, which is the chemical name, tripalmitoyl cysteine. It means it has 3 amino acids on it, and those are highly toxic. They cause the immune suppression.
So I'm kind of taking it in. Quite frankly, it's a lot of political stuff. There's some pieces of it
We said we were going to blow you away.
I understand, because a lot of it is very similar to the stuff that I know about from HIV work.
Yeah, and we look to the good work of the AIDS activists.
Oh, really? Okay.
As a model for how we get out of this 40-year quagmire, how we stop the deaths and the suicides and the children who are suffering.
And the homeless people.
And the homeless
my Lord.
people who are just kicked to the curb.
Well, and I know we're going to talk about the population of the subgroups we just voted on, but potentially that might be a way to integrate the efforts of those groups, because clearly the folks who are on those groups are subject matter experts in the various aspects. So possibly if we could include some of those experts on our subgroups, it might be a way to roll in what they're doing into this in an informal capacity into the official capacity.
Okay, I want to keep our momentum up here because we're doing great.
Do we agree with that? I mean, is this, are we agreed?
I guess the question I would ask is sort of what would be most useful to the committee. So it seems like there are a number, and this is going to be an issue, you could be saying this about any agency or any other entity within the federal government. How do you want to get this information? As a report, what you would like to kind of a summary of what's been done and what's come out of it and products, or to have somebody come and present on it and have a dialogue with them? I kind of think like, just think about what your information request is and what form you want to put it in is probably the thing to do. Okay.
Well, I certainly like the idea that you had about possibly bringing over, a few of the, I don't know who those people are that come to you in that particular tick-borne. That's a good idea. I was privy to that and on that webinar,
And that's why we won't tell our stories, because in the Lyme disease world, what that has become is decades of useless awareness that has not resulted in anything productive, and inward fighting of a race to who can die, the greatest martyr atop the highest cross. And it doesn't matter. It doesn't matter. My story is a dime a dozen, and your story is a dime a dozen. We don't know very many people with Lyme disease who are farther, unless they've recently acquired it, out of their 60s, because they either kill themselves, or what does a person with immune suppression or reactivated herpes viruses, what do they acquire? Cancer, and they die.
They're too sick, they're too broke from having to pay out of pocket for treatment that doesn't work because they're treating viruses with antibiotics, and their families have largely abandoned them because they believe the doctors who are saying, oh, Lyme's not a big thing.
They just
It's easy to test for it, and it's easy to treat.
Do something.
So one thing I would just kind of encourage you to do is when you think about your issues and what's important to you, and you think about the charge of the group, and as things kind of get a little further along and you see what the structure and process is, think about how you can raise these issues in a way that connects it to the work of the group.
First off, I'd like to remind the working group that Borrelia are relapsing fever germs, and just like the rest, they're capable of antigenic variation. That fact alone makes it a ridiculous notion to attempt to vaccinate against it, and asinine at best to say that vaccines for spirochetes work by turning human blood into tick disinfectant. Secondly, OSPE is pamphresis, a fungal-like endotoxin that causes immune suppression, and that means that it is the opposite of a vaccine.
So for example, you could say a number of these are gaps, a number of these are research issues that need to be addressed still. Somehow, I think that there'd be some ways to raise these.
The biggest complaint I have about the crazy controversy regarding Lyme disease is the vehement denial of facts, truth, and the real science that exists today. There is only one truth, not tailor-made versions of it to suit each and every one of us. This committee will have failed everyone if the U.S. government does not state for public record what exactly OSPE is.
So that you could see some of these things potentially be included in the report.
We will be truthful and we'll be authentic with you, and if we can't do something, we'll tell you we can't do it.
So in a moment, we're going to start the afternoon program. I'm going to give a moment to Pat Smith for a comment before then.
Yes, thank you. I just wanted to, based on what I had brought up earlier about the other federal working group and the fact that we are bringing in stakeholders from various places to report, and since that issue apparently has been unsettled, if no one has an objection here, I'd like to see that we put that on the agenda somewhere for discussion at maybe the next meeting or tomorrow's meeting or whatever, to invite them in to make a presentation.
Excellent idea. Thank you.
So that can become part of what we base our things on.
So if we never see you again,
Oh no, you'll see.
We're going to be around.
I'll be right.
Well, I don't know.
If we don't.
You see, but you'll be, well, so if you don't, I'm sorry.
We hope we do. Let's put it that way.
Remember us and say, well, they had my back. Because you were about to embark upon a journey that I think you've demonstrated some enthusiasm and passion about, and you were going to be completely hoodwinked.
Yep.
Nobody else is going to tell you this.